Good afternoon. I'm Harold Holzer, Director of the Roosevelt House Public Policy Institute at Hunter College. And on behalf of Hunter President Jennifer Rabb, I want to welcome you to the virtual Roosevelt House space we have been occupying for a year now to remain open to the public. And while we, of course, look forward to the time when we can reunite in person, we're really pleased to continue our roster of programs on the historic achievements and current challenges of policymaking in the city, state, and the nation. And what aspect of public policy could be more timely and more urgent than the subject of healthcare? That's why it's a true pleasure to welcome veteran award-winning journalist and healthcare authority, Jonathan Cohn, to Roosevelt House. An indispensable national voice on the modern history of our healthcare system, he is the senior national correspondent for HuffPost, and previously he held positions at the New Republic and the American Prospect, and he's written for a number of periodicals, including The Atlantic, the New York Times, and the Washington Post. His previous book, which was called Sick, The Untold Story of America's Healthcare Crisis and the People Who Pay the Price, offered an eye-opening exploration of America's deficient healthcare system through the harrowing stories of those most in need of care and least likely to get it. So we could not be more pleased to welcome Jonathan today to discuss his brand new book, The 10-Year War, Obamacare and the Unfinished Crusade for Universal Coverage. In what critics are already calling a definitive account, he chronicles the complete history of the Affordable Care Act and the fraught disagreements that have surrounded it both while it was being legislated and after. It's 11 years old this month, and it still continues even now to be litigated in the country's highest court. The 10-Year War tells the remarkable story of the challenges brought against the ACA, the persistent pushback by those who have championed it, and the reality of where it stands now. Readers will learn or be reminded of not just what has transpired, but of the conflicting strains of social and political thought that have brought us to this point. The book is based not only on Jonathan's past reporting from Washington and around the country, but on hours of new interviews with experts and activists, congressional staffers, and officials at the highest levels of government from both sides of the aisle, including former President Barack Obama. The result takes us behind the curtain and into the rooms where Obamacare happened and was challenged, from Capitol Hill, community town hall meetings to the West Wing, and later to Trump Tower. What the result is a totally fresh perspective on what is widely considered now in historical terms one of the most consequential pieces of legislation of the last half century. Now, to speak with Jonathan tonight, we are pleased to welcome Hunter's own Partha Deb, chair of the Hunter Department of Economics, as well as a faculty member of the Roosevelt House Public Policy Program. A specialist in the economy and economics of health, Professor Deb has published in leading journals like Health Affairs and the Stata Journal, and has served as a co-principal investigator in research funded by the National Cancer Institute and the Agency for Health Research and Quality. In 2012, he was named by the Obama administration as a senior advisor at the Center for Medicare and Medicaid Innovation, where he was devoted to helping improve healthcare quality as well as lowering its cost. Since the pandemic first struck, Partha has also been a vital voice for the Hunter community on navigating and understanding the full challenges of COVID-19. Most recently, he did so as a part of a Roosevelt House discussion on how to model the spread of the virus over time, offering policy recommendations to confront it. For that, Partha, we're much in your debt. I know that speaking for Roosevelt House, we will never forget your wise counsel, your reassurance, and also your frank warnings at the height of the pandemic. So thank you both for joining us for this timely and important conversation. As all of us wonder not only how we got to the Affordable Care Act, but also what happens next. With that, please join me in welcoming our special guest, Jonathan Cohn, in conversation with Professor Partha Deb.
Thanks, Harold, and thanks to everyone at Roosevelt House for making this possible. Thanks, Jonathan, for agreeing to do this. It's a real pleasure to be able to have this conversation. I know you've kind of invested in this journey for a long time and at great depth. As Harold suggested, I've been a small part of it myself. So I'm going to sort of let you describe in your own words the book, the genesis of the book, and as Harold suggested, sort of what it takes to come up with a history of a process like this. Right? It's really not just about 10 years, it's about maybe 20 years in the making. And I think it's important for people to understand what it takes to get to where you've gotten to in this book. That's something you don't get when you're not talking to the author. The words kind of don't have all of the subtext in it. But before you do any of that, there's something I learned about Jonathan very recently. And so I insist that he tells us something about why, in fact, Jonathan really is the Hunter College product. So welcome, Jonathan.
Thank you. Thank you for that introduction, and thank you for having me. I am beyond thrilled to be at virtually at an event from Hunter College because my mother, Elaine Cohn, who actually passed away just this past summer, was a very proud Hunter College graduate, bachelor's in 1962, master's in 1967. She was a public school teacher from New York City. She is one of those people. I grew up in South Florida. Part of the greater New York diaspora. But my mother in particular really spiritually never left New York, never left Manhattan. And in fact, when I would visit New York City, and I'm not making this up, I would take the Lexington Avenue line uptown. I'd get out at 68th Street and I would call my mom and I would say, "Mom, I'm in your favorite place in the world." She loved Hunter College. And, you know, her whole family, my whole family, and my dad's side too, for that matter, products of New York public schools, products of New York public universities, scattered throughout my lineage. And I always grew up, not just, you know, these are just, you know, you feel pride in where your parents went to school, where your grandparents went to school, but also just the idea of this wonderful set of institutions, really capturing the idea of a public good that the government could provide for its citizens, which I think actually is incredibly appropriate today. So I'm so excited to be doing this for that reason alone.
Great. So Jonathan, if you could start by sort of just providing some of the subtext, some of the context. What was it like? Kind of how much shoe leather did you get out of in gathering all this information, right? So I think it culminates with the big interview with the man, President Obama, but there's a lot of stuff that happens before and in fact after. So if you could describe that, that'd be great. Yeah.
So, I mean, obviously, as you said, you know, I've been covering this for what works out to most of my professional life in terms of healthcare. And I happen to be covering the healthcare story from the genesis of, you know, going back to my book, which came out in 2007. I covered the 2008 presidential campaign, the debate in Congress over what became the Affordable Care Act, and all the fights since it then. So I had all of that already kind of under my belt. And I'll be honest with you, when I first kind of pitched this book, and that's what you do as an author, you have to pitch it to a publishing house. It's a whole process. I kind of was envisioning a kind of quicker book. And my theory was, look, I know all this already. I've done this. I don't need to do that much more. And I can kind of just turn it around quickly. And actually, it was my editor who said, well, you know, we'll see. Take your time. you might find that to do a really, we need, to do a more definitive work, you might want to do some more research. So I started going back and looking back to all the old sources I'd had and new sources as well, and trying to get in touch with everybody, from the level of, activists and congressional staffers and policy experts who were not in the government, but were kind of advising this effort all the way up the chain, to the very highest levels. And every time I did an interview, I learned something new. Every time, and I got names of new people who I hadn't interviewed. And two things quickly became apparent was that there was a lot more to know that I didn't know. Also, there were many more perspectives, and I was very conscious, and I tried hard in the book to do this. You cover something for this long, I obviously have my perspective. I made that very clear in the book in the introduction. And if you read my last book, I come right out and say, I think healthcare should be a human right. Nobody should have to go without healthcare. No one should have to go bankrupt. It should be within, their financial means. But I tried very hard to expand the universe of people I was speaking to, because things that I thought I knew turned out to be, well, maybe they were wrong, or maybe they were just one perspective. And, the next thing I know, my handful of interviews that I was going to do became dozens of interviews spanning hundreds of hours. And actually it was hard because I ended up with a lot more material than I knew what to do with. And there's a little part of me that hopes that like someday, maybe when I'm retired, I can do like a direct, how Ridley Scott is always doing the director's cuts of his movies to have the extra scenes. Maybe I can get some of that extra material that ended up on the cutting room floor.
It's fantastic. So actually, Jonathan, I think you describe in the book, kind of just as a summary statement, that in fact the law, the Affordable Care Act, is flawed in many ways and sort of compromised in many ways. And from one perspective, that's not a surprise. It was big and complicated. We live in a big and complicated country, and healthcare is a big and complicated thing in that context. So in a sense, it's not surprising that a document would be flawed. But I think I'd like to connect it with sort of all these interviews and you learning along the way, because in fact, if it were simple, there would be one answer. It'd be simple, it'd be done, neatly packaged. Tell us a bit more, draw out for the audience here, draw out for people kind of what you discovered in the book about perhaps, I think flaws is the word you use, and flaws is perhaps technically correct. I don't want people leaving with the thought that, well, this was flawed in the sense that it was not improvement over status quo. I think both you and I agree this was a major step forward, yet there were flaws. So maybe you can kind of hit the highlights of what it really achieved and what you think the primary flaws are.
Yeah, so I think if you're kind of thinking of it as a ledger, right? Positive and negative. Two positives stand out for me, and I think they're really important. And then there are the negatives. And actually, let me start with the negatives, because I think that helps. I think it sort of flows more logically. So the obvious negative is you look around the country and we still have millions of people who don't have health insurance. We still have millions of people who have health insurance, but they can't pay their medical bills because they out-of-pocket costs, the deductibles are too high, or they can't afford, the $15 to pay for a prescription. We still have a system that's incredibly confusing. And I've spent some time overseas talking to people in other healthcare systems, and it never fails because they're, I'm interviewing people who are talking, I'm asking them about their healthcare system. They turn to me, well, what is America's healthcare system really like? And I just give them an example of a fairly routine interaction with, I'm not talking about something I had with my family. I've been, mostly lucky, not, dealing with major serious medical problems, and just the stories of how you deal with the insurance companies and figuring out what's covered and dealing with the provider networks. And if you talk to someone in most overseas countries and they just sort of give you this look like, what are you talking about? Like, what are you even putting up with that for? So we still have this confusing system. And of course, we have the world's most expensive healthcare system. And I've yet to see any evidence that we are getting a better healthcare system because we spend so much money for it. And there's clearly a lot of ways. So all of that was true before the Affordable Care Act, and that is still true today. On the other hand, it's a lot better, as you say, and I think there's really two ways that it's perceptibly better. First is, I think we've crossed a political threshold, and that's really important. If you listen to what Obama says on the signing ceremony, so if you go back in time to March 23rd, 2010, in the East Room, this is the famous one where, Joe Biden leans into him and calls it a big bleeping deal. In the prepared remarks, Obama talks about establishing the principles of universal coverage. And that's a very key way of putting it, because of course, when he first started out, he and most of the Democrats said, we are going to get to universal coverage. And obviously that wasn't going to happen. But the principles of universal coverage, and I think there's something to that. And I think we see that most clearly in the treatment of pre-existing conditions, which is something that really sunk in. I mean, that has sunk into the consciousness of the American people. And as I think Republicans discovered when they tried to repeal the Affordable Care Act, people care about that. They like that. I mean, whatever else they think about their healthcare system, whatever else they think about Obamacare, they like the fact that people with pre-existing conditions have a legal guarantee to get insurance. Whether it works out that way in practice, always we'll put that aside. But that principle has been established. And the proof, again, is the fact that in 2018 and in 2020, you heard Republicans bending over backwards to say, we support protecting people with pre-existing conditions. I mean, they sounded like Obama or Nancy Pelosi when they said it, or Ted Kennedy. And that tells you that, the politics have changed. And that's how political, those victories, those rhetorical, thresholds, when you cross them, you almost never go backwards. And so I think that's a real advancement. It's a shifting of the conversation. That's a political legacy. That's important. And then, of course, the other way I think the plus is there has been a human impact. And, we were just talking, who doesn't have insurance, who has high deductibles. But you know what? There's a whole bunch of people who got insurance. And there are a whole lot of people who are saving money now. And there are people who had pre-existing conditions who could get coverage before, but it didn't cover anything related to their pre-existing condition. Now they have real policies that have guarantees with them. And these policies are not perfect. If they're on Medicaid, there are problems with Medicaid. But, there's a lot of research now, and it shows very clearly, I don't think it's ambiguous anymore, that we're seeing people are overall financially better off because of this, medically better off because of this. And that matters. I mean, I go by the data, so I go by these studies, but I also am a reporter. I've spent a lot of time, and in the book, I talk about a few of these people. And it makes a real difference in their lives, perceptible, tangible difference. Not that their new arrangements are perfect, but they're so much better than they were. So that's how I kind of look at the ledger, the pluses and the minuses. And, to me, that's a pretty big step forward.
I couldn't agree more. So, Jonathan, let me push you just a bit on the point that you made about universal coverage. So I've always thought of Medicare as being universal coverage for the 65 and older, and some kind of who are younger than 65. So in fact, in 1965, there was already a model that was debated and was critiqued. But in fact, as you said, this was sort of benchmark setting in Obama's mind. Medicare was benchmark setting as well. That is, all of a sudden, if you were 65 and over, even in the US, you were universally covered. You write about it in the book, and I think that's sort of important. But what I'd like you to draw out, the two things. So one is the fact that, in fact, that was a model, that was a benchmark. But B, perhaps you can answer a question that I've had as we've gone through this process, and I've asked people every time I've had a chance, which is, why didn't Obama and others around him keep pointing back to Medicare? Every time I saw an elderly person with a sign saying, "Government out of my health care," I wondered what they were thinking. Right? They had government, fantastic government health care. So go ahead, give us a thought on that.
Yeah, so absolutely, Medicare 1965 law creating Medicare was very much one of those thresholds, and and actually I think is a really instructive lesson in how the politics of an issue change when you cross that threshold. We still have conservatives who don't like Medicare or want to change it. The key is they don't say they want to change. It's never I want to get rid of Medicare. It's I want to protect Medicare, and here's how I'm going to do it. And then if you dig into the details, you'll find it's going to reduce the funding, it's going to end the entitlement status, what have you. And I actually think that's maybe where we're eventually headed on the Affordable Care Act, maybe sometime soon. So that was a big threshold, and as you say, you look back on it, Medicare is wildly popular. It's even very popular with the critics of the Affordable Care Act, at least at the level of the voters. So why is it that how did that work out that we do have all those people who are saying, get the government out of my Medicare and I hate Obamacare? And this has been a phenomenon for a while. And I think there's a few things going on here. So first of all, there's a phenomenon that's been observed by political scientists for a long time, where people are complex. People have opinions about politics that may not always line up in the way you would like them to, in the sense that they don't seem to really fit. And that's not because people are dumb, it's because most people have a lot going on in their lives and they don't really have time to sit and think through. There are, Medicare, the idea that someone would say, keep government out of my Medicare. There is this, on the one hand, you have a lot of people who at the level of principle, at the level of slogans, they don't like government. They're against big government. They don't trust it. At the same time, they really value their Medicare and see that almost as something separate. It's a separate program. And, some of that is in the design of the program. Medicare and Social Security are by design universal programs. Everybody, and there's a sense of earned entitlement. And that's a really important distinction. One reason those are popular is people feel like they paid into them. I paid into my Medicare. I worked, I paid into Medicare, I paid into Social Security. I've earned that. And that's a really important distinction, and it really comes into play with the politics of the ACA, because the critique, the attacks on the ACA, a lot of them are about the fact that this perception that money is going from hardworking American taxpayers to people who aren't so hardworking. There is a thread of this politics that runs through in American history. It becomes quite ascendant after the 1960s and with the rise of Ronald Reagan. It is of a piece, I would argue, with the arguments about welfare queens that Reagan made so famous, and the perception that the ACA was only for other people. If you were a white middle class voter, I think was a big part of the opposition to the Affordable Care Act. And you remember, if you remember back to sort of the key moments in the fight during 2009 and 2010, there's that famous September speech by President Obama to Congress when Joe Wilson, the Republican congressman, shouts out, "You lie." Well, the thing he was, quote, "you lying" about was whether the new program was going to pay for coverage of undocumented immigrants, which play right into that same political trope of money from, hardworking American people, white Americans frequently going to people who are people of color and immigrants. And that was a very toxic political mix. And I will say, some of that was baked into the design of the ACA precisely because it was designed to plug the gaps. That was a deliberate design decision they made way before Obama was president. Democrats had gotten behind this vision of we're not going to change existing arrangements. We're just going to get help to people who need it. Well, by definition, that ended up being people who tended to be more low income, and that sort of that dynamic played right into the future attacks that went into the Affordable Care Act.
Super. So I'm going to ask you, Jonathan, just to pivot a little bit. There's a part of your book, and there's a part of the history of this that certainly for policy wonks like me is super important. but perhaps not as widely known, not as sexy, perhaps, for lack of a better term. And that's the Massachusetts plan, right? So the Massachusetts plan is a policy wonk's dream. It was designed by a bunch of wonks and somehow became law in Massachusetts, contrary to sort of many expectations. So if you could spend a little bit of time fleshing that out, because at least for someone like me, I see that as being the seed of what Obamacare eventually became, and a super important precedent for it.
It absolutely was the seed, more than I even realized before I started reporting. As I was interviewing people, including President Obama, I remember, one of the things I wanted to ask him about was, well, how did you kind of, come to in your presidential campaign? How did you land on this basic framework, which became, the framework for the Affordable Care Act? And I had intended to ask him whether the Massachusetts reforms were part of that. And without my saying anything, he went right there. And he's like, well, this thing happened in Massachusetts. Now, just to give a little background for everyone, most people watching this probably know, but the basic story of the lead up to the Affordable Care Act is in the 1990s, there was this, Bill Clinton was president. They tried to do healthcare reform. It collapsed. And there was a lot of soul searching about how do we not make the same mistakes again. And there were a couple of rules, kind of guidelines for what they thought would work. One of them was rely more on private insurance. One was don't mess with employer coverage. Try not to go really big on tax increases. Work with various healthcare industries rather than trying to overcome them, and get some Republican buy-in if you can, because the numbers in Congress are such you're probably going to need at least a handful of them to vote for it. So that this had already, by the early 2000s, there's basically a consensus, not universal certainly, but among the sort of mainstream, most influential, and there's a small group of them, but it's sort of the main group of intellectuals and activists, and they're all kind of coming to it for the same reason, because they basically are all like, we want something that's, we're tired of failing, we think this has got a shot. And then all of a sudden, boom, 2006, Massachusetts passes a set of reforms that fit this criteria, in part because one of the key advisors to that is one of those same intellectuals who had been working on this consensus, and that's an economist at MIT named Jonathan Gruber, and he's just one of several. But this plan comes to fruition, and really important. Not only does it pass, but it's got this, it's got a Republican governor who was essential in crafting it as well as signing it. I mean, Mitt Romney was the governor, and it wasn't like he was some figurehead. He's deeply in the middle of this process. He's negotiating, he's shaping it. He comes to believe in it. It was almost a kind of evangelical fervor, and presents it, emphasizing what he considers at the time to be its conservative quality, which interestingly enough is he's very taken with this idea of an individual mandate, a requirement that you get health insurance, because to him, that's a way of enforcing individual responsibility. He's very upset that there are people who could afford health insurance, aren't getting it, going to the emergency room. He's like, you should have to pay your share. I like this individual. So he buys into that for the individual mandate. It had conservative scholars from the Heritage Foundation praising it. And of course, the entire Massachusetts healthcare establishment. So the insurers and the hospitals, the labor unions, the employers, everyone's kind of on board with this. And so it's kind of like a eureka moment. I mean, it's proof of concept. And they all run with it. Of course, as case I make in the book, there were the lessons were fairly complicated, in part because Massachusetts had a few things going for it that wouldn't be true in the rest of the country necessarily. And if you zoom ahead 10 years to the implementation of the Affordable Care Act, and you see where it's kind of fallen short of where even the architects had hoped it would go, you can pinpoint a lot of that to, that's because this thing that was true in Massachusetts wasn't true in the rest of the United States.
Fantastic. Jonathan, let's take you to a space that got a lot of attention. Because I want you to pivot a little bit towards, I want to ask a question about a part of the Affordable Care Act that is perhaps not so well publicized, but is important. And you raise it in the context of the death panels conversation in your book. The death panels were about cost containment. So I'm putting my economist hat on now, and it's about cost containment. Yes, that there's a fundamental issue with the US healthcare system, which you mentioned early on, says that I can have insurance and yet I can go bankrupt. I can think I have coverage. I've got the basic protections. We don't let people die on the streets, but I could go bankrupt. My kids can be in real trouble, et cetera, et cetera. And so, in fact, cost containment was a part of the Affordable Care Act, again, drawing from the Massachusetts sort of ideas. And yet, cost containment became, in my view, death panels. And yet, my experience, so Harold mentioned earlier, I've been kind of advising a little organization as part of Medicare, essentially working on cost containment and sort of quality improvement. That seems to have flown under the radar, much to my pleasant surprise, I will argue. But I'd like you to kind of talk about death panels as the thing that for a while seemed like was going to tank the entire bill.
Yeah, I mean, I actually think it's a really interesting window into how the opposition and criticism to the Affordable Care Act materialized and prefigured not just how the opposition would continue to be to the Affordable Care Act in the coming years, but I would argue prefigures a lot of what we've heard on other issues coming from that part of the political universe in terms of the relationship between rhetoric that you hear from certain parts of the conservative universe, certain networks on TV that address the conservative universe, the relationship between that rhetoric and reality, which is frequently tenuous at best. The death panels starts, the original, and it's funny, it changed over time. So originally what happened was there was a proposal that basically said, hey, end of life planning is something that's a good thing to do. We always are encouraging people to do this. It's actually quite if anyone's been through this with a family member, it's a fraught topic. It's difficult. Being able to sit down with a physician you trust to talk about this would be a really useful exercise. The problem is Medicare won't pay for the physician to do that. So let's put something into Medicare which says, hey, if you want to give a half hour to a patient and give them advice and give them feedback, then Medicare will reimburse you for your time. Very innocuous idea, one would think. And in fact, it was a Republican senator from Georgia on the Senate side who thought this up. Well, there was a writer, a conservative writer, who happened upon this and twisted that into a requirement that you're going to have to sort of, there will be some kind of death panels that will require end-of-life planning. And it raised this specter, which has always loomed large in the debates about healthcare, that liberals who want universal coverage are actually out to ration your care. And at the end of the day, it will result in people who are older, who are sicker, who are deemed less productive for, one way or another, losing coverage for things they need, which is a very scary prospect to everybody. I mean, everyone wants to think, that frightens people. It's a very emotional appeal. As this sort of starts to play out, and it plays out in part because there's a particular member of the Obama administration, Zeke Emanuel, who's actually done some writing on these topics as a bioethicist. Now, the sad thing is, he'd actually gotten his start by sort of encouraging people to write living wills, because what he saw as a physician treating patients, and had actually written a lot very thoughtfully on end of life and how we think about it, and had actually written critically of medically supervised euthanasia, for example, but somehow ends up becoming the sort of poster child for they call him Dr. Death, and he's coming to get you, and Obama is going to cut off your care. And then at this point, Sarah Palin, if you remember Sarah Palin, enters the picture. And back in 2010, just not that far removed from her vice presidential candidacy in 2008, she's a beloved figure on the right. In addition, she is a especially heroic figure to people of all political persuasions for parents of children with special needs. And she comes out and says there's going to be death panels that will deprive care to people with disabilities. And now at this point, it's important to recognize the concept has actually shifted. And she is now associating this not with that provision about Medicare, but with a whole other proposal in the Affordable Care Act, which was a board, an advisory board, but with some power to change how Medicare paid for services. And this was designed to control cost, as you were saying before. And it was an idea that, again, it was remove it from the politics of 2009. And it's the kind of thing that you would have had some conservatives liking, some liberals liking, some conservatives not liking. It's a complex issue in and of itself that I think reasonable people could agree or disagree it was a good idea on policy. What it was not was a death panel. But she conjured up this image. It was very emotional. And it just became a rallying cry for what was assumed to be this giant plan to ration care for America. And the irony is, precisely because the whole architecture of the ACA was designed to get through Congress, they really shied away from anything remotely close to that kind of rationing. I mean, you could imagine a system, a universal coverage system, with a very aggressive control of what is paid for and what is authorized. I don't think you'd ever see anything like that in the United States. The politics wouldn't allow it, but I can at least, I can conjure in my head a proposal that looks like that. Nothing could be farther from what the ACA actually was, and yet they got blamed for doing that anyway.
That's fantastic. In fact, palliative care, which has grown more and more popular, could easily be twisted into a death panel. It's a conversation about end-of-life care, and sometimes aggressive end-of-life care is not what the participants in that process want. Yet that's a conversation that's very hard to do in the context of Medicare, in part because there is this overhang, there is this fear of anything on that front still being called a re-entry of the death panel. Fantastic. Jonathan, I see lots of very good questions coming in on the Q&A. So I am going to ask Mac to help us with those questions. And so let's carry on the conversation. If you haven't put a question in the chat, you're still more than welcome to ask. Throw it in the chat, please, so that we can moderate. This is a pretty decent sized group on Zoom. So Mac will help us go through the questions.
Thanks, Partha. Thanks, Jonathan. Just a small correction. The chat is disabled, but do put your question in the Q&A function.
My bad.
No worries. So a question from a health professional named Gordon. First, he says, I certainly support the idea of universal coverage in principle, i.e. no one should go without care or go bankrupt obtaining it. The question remains, who pays for it? What have we learned in the last 10 years about how to get to paying for universal coverage? Is it realistic, and how?
Yeah. So, I mean, in general, let's start at the level of high principle, which is that universal coverage, who pays for healthcare? We pay for healthcare. You and I pay for it. We are all paying for healthcare. What it happens in most countries is that the government collects the money or directs the money somewhere. It typically will set some kind of overall budget, or at least have some say over what the overall spending is, and then may or may not get more, at varying levels of sort of control over who is getting paid what. And, that could be anything from sort of just dividing up the hospital budget and giving hospitals money, or it could be dictating specific fees for specific procedures, what have you. And then, of course, and then in those countries, it's paid through some combination of taxes and premiums, but it's basically the population shares the expense broadly, more or less in the way a tax system normally would. So rich people pay more, poor people pay less. Sometimes it's not progressive, but that's the way it's done in most countries. We also pay for our own healthcare. We pay for it in a much messier way without that control. And so, for example, in my case, what am I paying? Well, I have an insurance policy. It's my wife and I have a employer policy. So we pay for that both directly. There's, we pay premiums, but then in addition, there's money that's not in our wages that we would get otherwise that the company is paying towards our health insurance premiums. And then we pay out of pocket costs, right? I pay for the drugs, I pay whatever, I pay at the doctor's office. Now, on top of that, I'm paying taxes for Medicare and Medicaid. On top of that, I am bearing the indirect costs, which is sort of built into all of those means for all the people who don't have health insurance or can't pay their bills, who are probably getting less care and worse care, but still it costs money and we pay for it. So is there a way to pay for universal coverage? There is. Every other country does it. The tough question and the tough political question, and this gets into why healthcare is so hard, is that it's very easy for me to say, gee, a country like France or Germany, and I use them as examples because those are two of the European countries I think widely thought of to have good universal healthcare systems, and also from the standpoint of the patient, they feel like the American healthcare system. I mean, delivery is similar, and there's free choice of doctor. It's a good patient-friendly system. I think most Americans would be quite happy in the French or German healthcare systems. So they pay. It's very easy for me to say, well, geez, they do this for 12 or 13% of their GDP. Why are we at 18%? We should just be able to do it for less. The hard part is every dollar that we're spending on healthcare now is going into it's somebody's income. And it could be a doctor's income. It could be a hospital company's income. It could be a pharmaceutical company's income. And try to take that money away, and it's going to be difficult. And it's going to be a fight, and there's going to be a debate. And there will be arguments that are ridiculous, like if you take away, X% of profits, the system will collapse. There will be arguments that are not ridiculous, which is, well, if you cut too quickly or too steeply, you actually might have some downsides and you might have deprivation. It's actually a hard thing to do to get from there to there. So I do think we can pay for universal coverage. We should pay for universal coverage. We're paying for a really lousy, inefficient form of it right now. But getting from there to a well-functioning system is actually quite a challenge.
That's great. A question from Robert Raber. First, a statement. No matter what kind of healthcare plan is developed to replace the ACA or put on top of it, how do you ever deal with the following problem? Certain doctors, good ones in many cases, decide only to see patients without the intervention of the healthcare plans in place. They will only serve people on their own private terms and conditions. In short, the system will still favor those who can pay for the best.
Yeah. So, there's two ways you can respond to that. And I favor one. I'll give you the two responses. Response number one is you can try to outlaw it. You can actually do that. You can say no one is you cannot pay, you cannot take outside money. There can be no concierge doctors, none of that. I'm sort of dubious that works. And I think maybe you end up with some kind of black market or something. But okay, you can do that. The other way is to say that's true. And there will always be the sort of private venue for the most well off. And you can sort of beat your head against the wall trying to get rid of that. Or you can really do your very best to make the main system generous and workable for people, recognizing that most people aren't going to want to spend what it takes to get that private doctor, and they won't have that kind of money. If the main system is really generous and works well, then the number of people opting out is going to be small. And frankly, we can have a philosophical debate about whether a system where Bill Gates can get, and the Bill Gateses of the world and, the top 0.2% are able to opt out of the system, whether there's something morally right or wrong about that. But at the end of the day, I think if you can get a system that works very well for 95, 97, 98%, then that's pretty good. Certainly much better than we have. And I'll say one more thing, that I get this question a lot. I will tell you, the urgency of this question is always a lot more urgent, no kidding, whenever I'm talking to people in New York City, which I interpret to be a fact that incomes, that I think honestly, like this is, I'd probably get the same, in parts of like Los Angeles and San Francisco, parts of New York City, but like in the highest income areas, you see this a lot because there's a critical mass of people who can actually afford that. But out beyond that narrow group of zip codes, in some of the biggest cities of America, you're just not, and I guess, wherever the Walton family is based in Arkansas, I forget the name of the city, you just aren't going to find a lot of people who are going to go that route. And so just focus on making the basic program really strong. I will say, I don't want to take up this too much more time on this answer, but when I sort of think of paths to universal coverage and where we might end up, my assumption has always been the sort of end state for American healthcare, given American politics, it's probably a system that looks like Medicare now, also very similar to what the French system works, where basically there's a public guarantee that sets a floor, and then people can buy up from that. And based on and they can do it to sort of insulate themselves more from risk, maybe to get into, a little wider choice of doctor. And then the government sort of makes sure to take care of people on the low end of the income scale who couldn't buy themselves up. That to me seems like where we probably end up, which again, that's a pretty good system. I mean, it's not perfect and there's inequalities baked into that, but the inequalities I think are much less severe.
Fantastic. Let's see. There are lots of questions, lots of good ones. So Philip Caper asks, and some of this you've already touched on, but Philip Caper asks, what are the implications of the takeover of the American healthcare system by large publicly traded corporations that has been underway for the last 40 years for costs, quality, and access?
So I've certainly seen studies suggesting that the more you see the sort of for-profit industry get involved, you see a kind of moving away from charitable mission, you see more efforts to extract profits. Something very much in the news right now that and I think there was just a new study this week. Well, there were two studies and I forget which one says which, but looking specifically at private equities investments in the nursing home industry and long-term care and the correlation there to quality of care and incidence of COVID outbreaks. So, I mean, intuitively, it seems like there's a big relationship there and there's certainly some evidence of it. If it sounds like I'm hedging, the reason is I've spent enough time sort of reporting on nonprofits that when you dig into, big nonprofit hospital systems in particular, and you'd start digging into them and wow, they're not, their MO sounds very for-profit-ish. They're profit curious, I guess. I don't really know what the phrase is. So I'm just a little bit reluctant to kind of put too much on the profit motive. And I say that as someone who's written before on the problems that the profit motive introduces. So I think there's something to that. It's one of those areas that the facts don't always quite work out the way you would think. And I can kind of imagine a world where we get to universal coverage and it's dominated by for-profit industry. It's not my ideal. I think it's still got problems. It's probably still a lot better, if we're at universal coverage, truly universal coverage, it's probably a lot better still than what we have now, where we still have so many people uninsured.
Meredith Balk has a question with several parts. I think all the parts are good. So I'm going to read the whole thing. Is it true that doctors make less income in Europe compared to US doctors, and that the EU medical schools are either low cost or free? And what are profits for EU health insurance companies like versus in the United States? And do they donate money to election campaigns as in the United States?
So the question about physician incomes is very interesting. I remember looking into this very specifically because, of course, you need to adjust two ways. And I think the answer is a little different depending on how you adjust. So first question is, do American physicians make more than their European counterparts relative to median income? Yes, I think that is fairly well established. And I do think, I've always thought in general that insofar as controlling healthcare costs may involve putting downward pressure on physician salaries, especially with some of the specialties, if you're going to do that, there's got to be a kind of deal here. And I think part of that deal has to be something that questioner mentioned, which is the high cost of medical education. I mean, I always sort of use as an example, just hypothetically, my college roommate is a surgeon now, and very specialized surgeon. And I've never had him do surgery on me, but as far as I can tell, given his reputation, is an excellent surgeon. He, we lived together in college, and while he was in medical school, worked incredibly hard, and then went through, there are things that are as demanding as medical residencies. I don't think there are things that are more demanding than medical residency for that many years. And he borrowed the whole way through. So, he's in his late 20s, and he's got a ton of debt. And, he's really not had a year yet where he's been making money and living comfortably. Now, on the one hand, lots of people are struggling. So, I mean, you can, whatever. But I think it gets to, it speaks to 2 points, which is number one, in general, when we think of our society and in a society where some people are going to make more money, do I think that, an ENT surgeon should be pretty high on that spectrum of people who make a lot of money? I kind of think so. I mean, that's a valuable thing. So you need to be mindful of that if you're going to try to, restrict. I do think, we need to do something. I think any formula for healthcare reform is going to involve getting into physician salaries, but you want to do it mindful of that. And this gets to the other part of the adjustment of how you think about European countries that I think is a little ambiguous still, which is that okay, we know that American surgeons make more than, say, and I'm picking this country out, I haven't looked at this country specifically, German surgeons, but do American surgeons relative to American, say, engineers, what is that differential compared to German doctors to German engineers? Because there is I do believe, even if you don't like worship at the altar of the free market, there are real dynamics out there about talent and demand and reward. And given the skills it takes to be a physician, you do start to think at some point if the money, again, a lot of this has to do with how quickly you make changes and what kind of changes you are. But, do you worry at some point that by changing the way physicians are paid, you're going to lose some of that talent pool that will go into other areas? So you have to think through all that. And I don't know what the answer is on that. There was one study I saw, it was not perfect. But it's an interesting question. But in general, yes, we pay our doctors more than they do in other countries. And that's true for most of our healthcare sector.
Ravi Chandran asks, what have been the political roadblocks that have prevented the lowering of the Medicare age to at least allow for a buy-in on some prorated contribution formula?
I mean, it's the same political roadblocks for Medicare for all, just not quite as severe. But I mean, this was actually in the ACA fight in 2009. This was the last offer on the table. They wanted a public option that people would be able to enroll in. First, the original idea was to have a public option anybody could enroll in. By the time Obama gets elected and they're pushing a bill through Congress, it's a scaled down public option only for people buying coverage on their own through the exchanges. By the time it gets through the House and this first of the Senate committees, it's been downsized further. It's less powerful. It has, it's been weakened in various ways. And then they try to eventually, Harry Reid, who's the majority leader in the Senate, is trying to put together the final bill. And basically a handful of senators, but the most notorious and visible of them, Joe Lieberman from Connecticut, says, I will not vote for this if it has a public option. I will filibuster the bill and it will be dead. So they come back with a new offer, which is, okay, let's do a Medicare buy-in. And that was supposed to work because Lieberman himself had endorsed the idea once. It felt less radical. And yet at the same time, if you were a sort of fan of Medicare for all, that's better than a consolation prize, because there's always been a theory, how are you going to get Medicare to everybody? We'll just, gradually expand the age bands. And he opposed it. And why he opposed that, and probably there were others. I mean, I can tell you there was a conservative philosophy issue here. It's more government. If you ask Joe Lieberman, he will tell you, I thought it was going to have to be subsidized by the taxpayers. I didn't want more government spending. The CBO, to be clear, actually thought it would save money in the end, but that was his argument. And then, the usual gauntlet of special interests. The insurance companies didn't want it because it was competition. The hospitals didn't want it because they perceived correctly, the whole point of a public option was to pay them less money. The AMA did not want it for the same reason. The drug and device, this is always the problem. This is why healthcare is a big reason why healthcare reform is so hard, is you have these powerful industries that are gonna protect their revenue streams, and they have money. They spend it on advertising, they spend it on contributions, and especially the drug industry, although there are others. The pharmaceutical industry owns the United States Congress. I don't feel like that's an exaggeration. It is very, very hard to beat pharma.
Yeah, following up on the topic of political roadblocks, an anonymous questioner says that countries that have managed to transition to universal healthcare have done so with great difficulty, including pushback from doctors and the healthcare industry. Does the U.S. follow this pattern, or are there unique obstacles here that other countries have not had to face?
Does that have to be an either or? we face those same obstacles. And I also think there's a time issue, which is the later in the sort of life cycle of your healthcare system you try to go to universal coverage, the harder it is because the system is that much more entrenched. You know, it's a lot easier to rearrange the financing of your healthcare system when it's 6% of GDP than when it's 18% of GDP. You know, if Franklin Roosevelt, if you go back in the time machine in the 1930s and say, really, please add, you know, healthcare to the Social Security Act, like you're thinking of doing, boy, that would have been a lot easier because there was no giant hospital industry in America. I mean, there were hospital lobbyists, they had influence, there were I mean, and partly he was afraid of, in part, the doctor lobby, but they were not as powerful. They didn't have as much money at stake as they do now. So that is all familiar. We do have additional issues, which is, you know, this speaks to a much broader issue that beyond healthcare, American politics today, American government, first of all, has a lot of choke points in it. I mean, that's the design. It's in the Constitution. You have to get through the House, you have to get through the Senate, you have to get through the White House. It has to withstand the judiciary. And now, assuming you kind of run that gauntlet, you're first dealing with the fact that we're a federalist system. And depending on how the system is designed, you're going to have to get the states to work with you too. And so that's a lot of choke points. It's a lot of places where resistance can stop something. A lot of veto points is another way to think of it. So that is a fairly unique American problem. We have a money and politics problem that I think is worse in this country because of the way we finance campaigns. And, you know, sometimes money and politics can skew to the left, but on healthcare, I think it tends to skew in favor of big business, you know, away from interest, that it makes it harder, certainly, to get money out of the healthcare industry. You know, and now and then there's the political environment of today, which is just, we're in this very strange political moment of a very, what I consider a very dysfunctional political system for reasons that have to do with a confluence of the specific design of the United States Senate and how the US population is distributed, and the creation of a right-wing media network universe that is increasingly self-contained and kind of walled off from reality, for lack of a better word. And these make it awfully hard if you're a progressive to get stuff done.
We're coming up on the end of our time, but if it's okay with you, I could do a couple more before we wrap up. Sounds okay. Emmanuel Zebeda, I apologize for that pronunciation. In your chapter on sabotage, you talk briefly about how Republicans defunding risk corridors killed almost every nonprofit health insurance co-op. Moving forward, do you believe a Democratic trifecta will mean a brighter future for insurance co-ops, or will a public option make political will for co-ops obsolete?
Yeah, I don't think the co-ops are coming back in a big way. I mean, that was, you know, the co-ops were designed partly as a consolation prize on not getting a public option. The champions of them were predominantly conservative senators from rural-ish states. I think the co-op idea in particular had a sort of particular Midwestern, you know, appeal to it. You know, the big champion was Kent Conrad from North Dakota. This was really his, you know, he was the big advocate for these. And, you know, some of them would have, you know, I was in looking into the one in Nebraska, Iowa, looked like it was, you know, it was a nice insurance option, actually. My guess is, I think at this point, one of the lessons more liberal and progressive Democrats have sort of taken away from all of this is, let's stick to what we really want. You know, if, you know, publicly run, government run insurance. We think it's better, it's simpler, it's more efficient. You know, we'll fight about how many people can cover, things like that. But I think they've about had it up to here with trying to sort of, you know, work different models that include private insurance, that, you know, that sort of sacrifice what they think is good about government run insurance. Now, I will say this, though. I would not be surprised at all if we get into a debate about a public option and the end game on this is a public option pass that actually really isn't a public option, but like it's called a public option and it has the name of like a public option, but then you dig into what it actually is and it's another private insurance. And maybe even it looks like the co-ops, I don't know. So maybe as a backdoor way, maybe we do end up back with the co-ops that way.
Interesting. Ravi Chandran asks, are there specific public health initiatives beyond what's been done or is being done to confront COVID that should be implemented to lower healthcare costs?
So getting slightly out of my sort of what I consider my real specialty here, I tend to think, yes, there's always public health. I mean, we dramatically underinvest in public health and programs that work, tobacco cessation programs, right? Addiction treatment. I will say there's one thing great. I think when people talk about the ACA and most underappreciated parts of the ACA is the money that has flowed into community federally qualified health clinics around the country. And I talk about this in the book. It's not just that they got, because more people have insurance and they get a bump and their money they get through Medicaid and direct subsidies, it went up because of the Affordable Care Act. So they can serve more people than they could before. But what's really remarkable, and I've seen this in so many clinics now, and there's data on this too, is so many of them have added services. And some of this is just they do a better job. They can do more screening, preventative care, cervical cancer, things like that, hypertension screening. But then also, I talk about a clinic in Los Angeles. I've spent a lot of time over the years. Whenever I'm in Los Angeles, I visit this clinic, and they've done such interesting and innovative things with, like, they have diet clinics and they have a kitchen, like a sort of cooking class paired with a sort of twice a week produce market that they bring in. And of course, this is in the middle of a very low income part of Los Angeles where historically it was really hard to find fresh produce. And they do also things like where they send social workers into homes to do inspections of, like, do you have lead paint? What kind of environmental hazards do you have? What are the sort of risk factors here for asthma? Because these are all things that your landlord should be fixing up and is legally obligated to fix up, but someone's got to sort of bring it, make them do it. And they will sort of document it and then hook you up with the lawyers, the public interest lawyers, to make it happen. And this is all because they have extra people. And that all pays off, I think, in better health. It's going to take some time to see the effects, but you see that. And I think it's a really, like I said, underappreciated upside to the Affordable Care Act.
That's excellent. And we're about at our hour mark here. So I'll just ask if you've got any final thoughts before we wrap up. I thank you, Jonathan. This has been spectacular. Thank you, Partha. I know the audience has learned a lot, and we've got lots of questions because of how interesting this has been. Thanks to everyone who has joined. And I'm sorry we couldn't get to more questions, but any final thoughts, Jonathan?
Just thanks again for inviting me. And I hope people, take away from the book, 2 lessons. There's a lot to do, and there are policy lessons from what went wrong with the Affordable Care Act, where it hasn't done everything we wanted to do. But I also hope that people can appreciate the positive of what was done, how hard it was to do, and recognize that governing is tough. I mean, that was the big lesson I learned from it's just so much harder than I thought. And there's a delicate balancing act, and I don't know where the balance is. But there's a delicate balancing act between saying, this is still a problem, we need to do better, this is what our ideal looks like. And being able to say that, because that's so important, but also being able to say, hey, we did something here that made a big difference. It was important, it has helped. And we should recognize that as an important victory. And that's a hard message to get across, but I hope, both of those things, whether you just listen to this or you read the book or just you think about policy in general, I hope it's possible to hold both of those messages in your head.
Absolutely. Partha, anything before?
Super. Yeah, I was just going to say this has been fantastic. I think, Jonathan, we could easily go another couple of hours. This is obviously important stuff. This is stuff people think about. It's been a wonderful afternoon. I'll just say one thing very quickly. As you were talking at the end, I was thinking, in response to, I think, Ravi Chandran's question, the first thought that came to my mind was, in fact, the FQHCs and the farmers markets that are setting up by these health clinics. And in fact, there is evidence now that where those exist, folks eat more healthier, basically, right? There's kind of more servings of fresh fruits and vegetables going in. So if you believe that actually matters for health, then in fact, that's the savings you see in the long run. Anyway, this has been fantastic. Jonathan, we'll have you back when the subways are safe and clean. Well, maybe not clean, but safe. We can bring you back to Hunter.
I would love that.
Roosevelt House.
They shouldn't be clean. It's not right. That wouldn't feel like home.
Yeah, that's right. Exactly.
Okay, thank you both. With
Great.
that,
Thanks.
Good afternoon, good evening. Bye-bye.